Hello, my name is Angel Cantos. I'm going to talk about Ribavirin for chronic hepatitis E virus infection in transplant recipients. Definition: Hepatitis E is a liver disease caused by infection with a virus known as hepatitis virus. The virus has less for different types, genotypes 1, 2, 3, and 4. Genotypes 1 and 2 have been found only in humans. Genotypes 3 and 4 circulate in several animals without causing any disease and occasionally infect humans.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HEV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
So I hope you liked this video. Absolutely make
Application in medicine. The hepatitis E virus is transmitted mainly through the fecal oral route due to fecal contamination of drinking water. This route accounts for a very large proportion of clinical cases with this disease. The risk factors for hepatitis E are related to poor sanitation, allow virus excrete in the feces of infected people to reach drinking water supplies.
Hepatitis E is RNA virus. Spread by the fecal oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. prolonged uremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank
Pros and cons. In rare case, acute hepatitis C can be severe and result in fulminant hepatitis, acute liver failure. These patients are at risk of death. Fulmination. Hepatitis occurs more frequently when hepatitis C occurs during pregnancy. Issues applied in Ecuador. Every year, there are an estimated 20 million HEV infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis E.
Hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure or a week or so prior to onset of symptoms and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatched line, and IgG anti-HEV, illustrated by the black hatched line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks. HEV serologic testing in persons with acute hepatitis, for which other causes have been ruled out, may be performed, especially in someone who has recently traveled to an area where HEV infection is more common. Chronic HEV infection is rare, but has been increasingly recognized in immune-compromised patients. Immunoassays to detect anti-HEV are commercially available, but are not FDA approved. Nucleic acid tests for the detection of HEV RNA are performed in research labs, but are not commercially available. This segment is now complete.
Conclusion. In conclusion, ribavirin as monotherapy may be effective in treating chronic HEV infection. A 3-month course seems to be appropriate duration for this therapy, though a longer therapy can be given to heavily immunosuppressed patients and those who still have viremia 1 month after the initiation of therapy.
El virus de la hepatitis E es un virus que se transmite también por aguas contaminadas, alimentos contaminados en formas epidémicas y que siempre hemos considerado que estaba fuera de nuestro país, de Europa, que lo cogía con la gente cuando iba a la India o cuando iba a México. Pues no, ahora sabemos que ha vivido con nosotros siempre y que es una causa de enfermedad que al haber desaparecido las otras, cada vez la vemos con más frecuencia. Y tiene la particularidad de que hay animales que son portadores del virus, fundamentalmente el cerdo, el jabalí u otros, y por lo tanto en el manejo de los alimentos crudos o la toma de los alimentos puede ser fuente de infección. Normalmente es benigna, aunque cuando coge a alguien que tenga ya otra hepatitis puede ser grave, y hoy día existe ya vacuna para este virus, pero que no tiene una amplia difusión en nuestro país, solamente en algunas partes del mundo.
Immunotherapy in renal cell carcinoma. Definition. A type of kidney cancer that begins in the lining of the small conductor of the kidney. The renal cell carcinoma is more common in older men. Risk factors include smoking and obesity.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin 2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more information about list of expert doctors,
Application in medicine. Several recently discovered drugs that influence the process of blood vessel formation and or the growth of cancer cells are being evaluated as target therapy for kidney cancer.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is two co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population there was about 40% of them, as well as an intent to treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the Emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second-line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
Pros and cons. Pros. Advancing genomics and biological discovery that can be safely targeted to benefit patient. Development and new therapeutic agent. Cons. Risk factor for renal cell carcinoma include smoking, obesity, and hypertension, as well as acute cystic kidney disease associated with end-stage renal disease. Prognosis is closely related to the stage of disease.
checkpoint inhibition, that is actually a form of immunotherapy. So that whole class of therapy, what it essentially does is ramps up your own immune system and releases the brakes that the tumor created to slow down your immune system from fighting your own cancer. It lets go of the brakes so that you can fight the cancer yourself. And when it works, it is actually astounding. It's really quite remarkable. It doesn't work for everybody, but when it works, it's really quite remarkable. Well, interestingly, checkpoint inhibition, again, this immunotherapy approach, that has exploded on the scene for bladder cancer as well. And that is rapidly changing the paradigm for the management of advanced bladder cancer. And so there's active trials ongoing right now trying to figure out exactly what space that therapy should fit in. Should it just be in metastatic disease, or does it have a role in locally advanced disease, or even earlier stages? So that is probably the single biggest advance in the last couple of years, and it's just taking bladder cancer by storm.
Issues applied in Ecuador. In Ecuador, renal cell cancer represents 2.5% in the male population, while in women it represents 0.9%. According to studies conducted such as the Global Can, indicates that incidence of renal cancer is 3.4%. One of the treatments used for this disease, immune checkpoint inhibitor therapy. These are used to treat some patients with advanced renal cell cancer that cannot be removed by surgery.
I think that kidney cancer is a fascinating disease, and I think that there's been an explosion of information about kidney cancer. I think that was one of the first tumors by looking at the patients with von Hippel-Lindau's disease, which is an inherited form of kidney cancer, to begin to understand the genetics and the genomic factors in kidney cancer. And that's led to the tyrosine kinase inhibitors, the mTOR inhibitors, and now, while we've historically believed that kidney cancer was a tumor that can be treated by the immune system, with the checkpoint inhibitors, we see now a new, renewed interest in treating kidney cancer using immune therapies. And I think that again, cancer is a very heterogeneous and diverse disease. Just like there's heterogeneity and diversity in normal people, there is a lot of heterogeneity and diversity in cancer. And so no one approach, it's not going to be a one-size-fits-all. The goal in the future of cancer therapy is to identify biomarkers which help us predict which treatments to use, potentially even which combinations of treatments and which sequence of treatments. So it's complicated. I think that you know, the President Obama is talking about precision medicine and putting more money into precision medicine, and absolutely, but it's not going to be so simple. There's a real significant complexity, but I think that we're much further along than we were. And again, you can't emphasize enough the importance of basic science research. One of the things that we keep coming back to with cancer is we need to understand the biology of cancer better. And as we understand the biology of cancer better, we're able to identify therapeutic targets to treat. And then ultimately, in our country, let's try to prevent cancer. And that's something that, again, by understanding the biology of the disease, potentially we can identify the triggers that turn on cancers and how to potentially alter those triggers.
Conclusion. The poor prognosis of renal cell cancer demands an aggressive search for the new therapy agents and strategies. In immune responses of renal cell carcinoma provides of opportunity for development and optimization of vaccines and other immunotherapies.
I think it's a truly exciting time. I mean, bladder cancer has been pretty much neglected for decades. We only had cytotoxic chemotherapy that had some modest efficacy, I would say, in patients, and now we are witnessing a true revolution with the approval of 5 immunotherapies. We are still, I think, working our way through in how to best identify patients who may benefit from these therapies and how to improve these therapies. But I think we are witnessing very durable responses in a subset of patients who can benefit from these therapies for years with really sometimes minimal side effects. I think this is truly gratifying for any medical oncologist. So kidney cancer has always been kind of like a immune responsive tumor. It's really the only other cancer where we have essentially old-fashioned immunotherapy a la high-dose interleukin-2, similar to what we use in melanoma, approved with long-term benefits. So since November 2015, we have nivolumab approved, a PD-1 inhibitor, and we do know that we can induce very durable responses in a small subset of patients, around 21% of patients. However, simply speaking, it's not enough. And I think the future is going to be to look at combination therapies. This will come forward in the short term, I would say, in 2 different flavors. One is the combination with VEGF inhibitors, and the other one in combination with another immune checkpoint inhibitor called CTLA-4 inhibitor, or Yervoy. And I think we will witness in a very short amount of time how the first-line therapy for kidney cancer is going to be transformed. It's going to be driven by immunotherapy, truly.
Thank you.